Welcome to Breaking Point, a podcast from CAPC, the Center to Advance Palliative Care. In this limited series podcast, CAPC invites healthcare workers from across the country to share their eye-opening stories from the front lines of the pandemic. Listen as they give us an unfiltered look at their reactions to the demands they've encountered and the coping strategies they've employed as they reach their breaking point. Your host today is Dr. Diane Meier.
Hi, everybody. My name is Diane Meier. Thank you for joining us on this episode of Breaking Point. Today, we are fortunate to be joined by Stephanie Terauchi. Stephanie is the medical director of Palliative Care at UT Southwestern Medical University in Dallas, Texas. And you may have been following in the news the challenges that Texas has been facing throughout this pandemic. And so, Stephanie, we'd be so grateful to you to share the story of what you and your team and the patients and families you serve and the organization you work in have been going through for the last couple of years.
Sure. Thank you for having me today. This pandemic has been a very, very long 2 years. And just when we think we are coming to the end of it, it hits us again. This third wave of COVID with the Omicron variant really, I think, caught a lot of us by surprise. We weren't expecting to be in the thick of it yet again. So this is very much a marathon. This is not a sprint. These patients that we've been seeing in the pandemic are very sick patients, typically what we are used to in palliative care, but there's a heightened sense of emotion and stress, anxiety just around everything that is going on in the world, in our personal lives, and not only what is happening at work and with our patients. And while palliative care is cut out for this, we train for this, right? These are our patients. We're used to seeing tragedies and sad stories and helping patients through a very difficult time. The pandemic is different from what we've seen. There is a lot of suffering just from the isolation. And that is what is different from what we normally do in palliative care. People aren't normally isolated or dying alone. We don't have visiting restrictions in our hospital where they can't come in. I was at the bedside of dying patients holding their hands, and now I'm in all this gear that makes me impersonal, or I'm not even allowed to go in the room. And that has caused an even higher level of distress for my colleagues, for the nurses, for the ICU physicians, for really everybody, because the way that we are taking care of these patients is not normal anymore, and the situation is not normal. And we have had to deal with a lot of change. So it's been a hard 2 years. And we get through one end of a COVID spike. We're good for a minute. We think, oh, we can let our guard down. We can get back to normal, go back out into the world, and then it just hits again. And so it's been hard to live that experience over and over.
Yeah, inconceivable. I wonder if you could talk to us about maybe some stories about the reaction of members of your team to this and how your team handled that and responded.
Everybody on my team has a different set of circumstances outside of work, married with kids, varying ages, some going to school, some having to do virtual school at home. So there's been a significant amount of change in people's personal lives that we have had to adapt to, which have been hard. Sometimes there's people on my team that don't have childcare for the day. And so, they want to come to work, they're well and able, but who is going to take care of their 2 kids that cannot stay home alone? So we've had to create the option for remote work. Particularly some of the work that we do have done over the pandemic can be done over the phone and calling patients and families and doing assessments through virtual platforms. Our hospital has Blue Jeans, and so the TVs in the patient's room, because we're a brand new hospital, have the smart capabilities to do video conferencing, and that's been kept us, working when we couldn't be there in person. So there's a lot of anxiety about going to school. Should I put my kids in daycare? Then that's impacted people's everyday work routines as well. People being able to, what time can I come to work? I need to leave early. And we've had a surmounting amount of consults within our hospital system. So there are some days we had 22 and 24 consults, people waiting to be seen. And then we have all these circumstances that are outlined. I can't come to work today because I don't have any childcare. I don't feel good. I might be sick. I need to now sit out a day to go get my COVID test, which is never one day, it's two, and to get the results and, things like that are happening. So it's been hard to juggle the volume with all the personal circumstances going on. But our team is really wonderful. We have to give each other grace during these periods, and we've had to adapt and we've had to be flexible. I'm the leader. And so I've had to accept that somebody can't come today, and that remote work is just the best we can do that day. And also we've had to wrap our heads around a bunch of high achieving people wanting to complete 22 consults in a day, that is just not possible. So every day we get there, we have to figure out, what can I do today that makes a difference? How many patients can I care for today? And to focus on that smaller number instead of the never-ending consult list and infinite volume of palliative care work and patients to see. And we do a good job at what we can do today. And then tomorrow is another day.
Right. Those of us in palliative care are rescuers, and we can't stand to see suffering that can be ameliorated unaddressed. And yet we are human, we are finite. And the need for palliative care, as you said, is basically infinite. And we can't meet an infinite need. We can do as much as we can. Have you experienced difficulties or challenges with staff retention or turnover during this time?
Fortunately, we have not had anyone leave due to burnout or things. We had one person resign from our team after having a new baby in the middle of a pandemic, and then commuting 1 hour each way was impossible.
Yeah.
That's 2 hours in traffic. That's pretty much a big waste of time. And it's also exhausting. So fortunately, we have retained staff, although there have been periods during the pandemic where we have had people sick and on quarantine, and we are a small team. We have, 3 doctors, we have 1 on maternity leave. So if anyone, and we have 1.5 APPs, if anyone is sick, it is a big difference in our staffing. And so, we've had to kind of learn to deal with that.
Yeah, it's again accepting finitude and the limits that come with being human. Tell me how your team has perhaps changed, how the perception of your team has perhaps changed at your hospital during this period of time. In what ways has your role evolved and the sorts of things that you do? You mentioned at the beginning something that I want to quote: the pandemic is different, period. That the kinds of patients we take care of, the acuity of their illness, the unexpected nature of their illness, it's like a sudden illness, not someone who's been living with COPD or heart failure or cancer for years and has time to kind of spiritually and existentially prepare themselves for serious illness. This is a totally different disease type, really frightening and comes on fast. So I wonder about what you've observed in terms of your team's relationship to your colleagues and to the rest of the hospital and health system.
I think our relationships with each other within the team have been strengthened. We are a really close-knit team. We have about 15 people on our team, and everybody is very supportive of each other, people checking on each other, and covering for each other when that's needed. I have seen the team come together to every morning, we have this big list of work to do, and it's a divide and conquer, but everybody is functioning at the top of their license. We taught the social workers how to do goals of care conversations, and we built them a template of questions to ask to help guide them to get the information so that they could see consults by themselves instead of a clinician, because we just didn't have enough to go around. And outside of the team, the relationships with our referring providers have grown. We got very close with the ICU. We embedded a palliative care physician into the COVID ICU that helped develop a communication team. We were the ones communicating with families, creating the message, what should we tell the families, and supporting the ICU APPs, the nurses, the respiratory therapists, the ICU physicians in their day-to-day work. And now that has created a very big sense of appreciation and respect for what we do. And now half of my census is the ICU. They want embedded palliative care within the ICU every day for every ICU patient, not just a COVID patient. And through that, our ICU is pretty much run by a resident team. So we've been able to grow those relationships as well and teach them, I cannot see this patient, but here are the steps that I would follow, to start these conversations. Let's think about your headline. Let's think about how to respond to their emotions and what things. So we've been able to teach the teams how to do the basic primary palliative care. So we've been able to, see the specialty ones. But also, I think with the hospital administration, they've come to rely on us. I've been in way more meetings with administration throughout the pandemic as a key player and stakeholder sitting at the table trying to sort through solutions to some of the challenges that we're facing. And I think that's an excellent place for palliative care to be.
How did you make that happen? I mean, there must have been things that you did or ways that you were as a leader that made the people in your C-suite recognize you as an effective leader and as someone who should be at the table. And I wonder if you could tell us, looking back, what enabled that?
So palliative care at our institution is incredibly well supported, and we had been an evolving service before COVID. However, when COVID hit, they knew that these cases were so sensitive. They know the support that we provide to patients and families, particularly at end of life with serious illness. But they recognized us very early on as a valuable service. But as they used us more, they really saw firsthand. Our CMO is an ICU physician, and he was integrated in the COVID ICU from an administrative standpoint, but also from a clinical standpoint. So I think that really helped. But we work really hard to build our relationships with these physicians who also serve in administrative capacity. I am, telling them what palliative care is and does. And, I'm rounding in the hospital, I'm present. I'm on the front lines with the rest of my team, even though I'm also doing administrative work on the back end. And I think building those relationships and just talking with people, listening, how can I be helpful? What are your challenges? And helping to offer solutions has really been part of our growth and involvement in the hospital.
Yeah, that's that issue of focused attention to relationship building, both as a leader and as any member of a palliative care team, And by relationship building, I mean not just with patients and families, but with our colleagues, is so critically important, and often not explicitly how we think of our role. But our colleagues are suffering too.
Mhm.
And I'll never forget a time when a young person that had a failed bone marrow transplant was being considered for a second bone marrow transplant. And I saw the hematologist who was taking care of her and just went up to him and mentioned the patient's name. And I said, "This is such a tough case."
Mhm.
And he started to cry. I mean, this is someone that I've never, seen any emotion, but just being acknowledged
Yeah.
that how much he cares about this patient and how distraught really he was about the failure of the first transplant and tormented about whether to recommend the second one. Just that makes a huge difference. So aside from building relationships with colleagues and with leadership, obviously you've done something right, given the power of your team and the unity of your team and the retention of your team. What sorts of things do you do as a leader to help your team stay connected and stay psychologically safe and healthy?
Our team has increased communication and just periods of time in which we're together to share what's going on and to work collaboratively as well to see the patients. So one of the things that we did was we have a daily team huddle, and that helps us come in every day, figure out what we need to do. But it's also a time for people to say, "I need to leave at 2:00. We've made virtual options so that people, who have a hard time, they've got to drop their kids off at school or whatnot in the morning, don't feel super pressured to get there on time." So I think we've created flexibility and a lot of grace and a lot of extra communication. I feel that because we support each other, there's really no judgment on, you're not less of a team player if you have to leave at 2:00 because you've got to pick your kids up from school. Everybody's doing what they can. So we assume the best in people. We assumed good intentions. And we know that one day, it may be my turn that I'm sick, or I got to leave earlier. I got to come in late. And I want the same compassion and grace extended to me that I would extend to other people. And that is what is shown on our team every day.
And you think that's key, that sort of welcoming of flexibility and tolerance of flexibility is key to the team cohesion and sort of commitment to one another.
It helps because, the people are not thinking, well, I'm the only one doing all this work and somebody else is doing less, because that's not what it's about. Everybody's doing as much as they can. It just may be different from day to day on what they can do given the circumstances of the pandemic. And so I feel that creates a culture of being able to understand people and, again, to assume the best intentions and to give people grace for what they're experiencing. And no one takes advantage of that because we have a lot of very hard workers on our team, very many type A personalities. That's not, what anyone is about. So
yeah it kind of reminds me of back in the day when I was an intern and a resident, how no one would leave till everyone was done. Everyone had everyone else's back, and it was that sense of being part of a unified family that made the work not only tolerable but pleasurable in some ways because of all those great relationships. And that seems to be what you're describing. Have you had any difficulties with what's in the news, the tremendous amount of burnout, depression, some people feeling like they don't think they can continue to work in healthcare anymore. Has that hit you guys?
Yes, I think that people throughout the pandemic have had varying levels of burnout. That's normal when you're working so hard and you're kind of burning the candle at both ends and you're witnessing the suffering to the level that is more than normal. I think we have to acknowledge burnout and we have to normalize burnout, and that it is not failure of a person to feel burned out. It is just bound to happen from time to time.
Right.
When we can recognize it, we can say, whoa, I'm headed down that path and I need a break. I need to go home today. This is not, I should not be here in the mindset that I'm at. And it goes back to creating that culture and having grace to be able, and understanding to be able to allow your team members to say that. And as a leader, I am human just like they are. I'm not any better just because I'm the leader. I have burnout too from time to time. And I have had to say myself, I need to go home today. And they look at me and they're like, okay, you go home, we've got this. And I'm like, I'll be better tomorrow or the next day. And we've allowed that space, and tried to, counsel with each other and just support each other to say, we're only human, we can only do so much. And it's okay to feel that way. Fortunately, I think we've all been able to stay on, we can, out of the severe stages of burnout that leads to people leaving the profession because we are stopping ourselves earlier to say, I need some help or I need a break. Mm-hmm. I know some of my employees have probably used the employee assistance program to get some extra support there. People definitely have anxiety about COVID and just fear of catching it and just anxiety about change and things. So, we just try to acknowledge that, and it's okay to feel that way from time to time.
Sounds like you brilliantly applied all the principles and practices of palliative care for patients to yourselves and to your team and to your team culture, which is people being able to say out loud what they're feeling. Mm-hmm. And not feeling ashamed or needing to hide it, or and of course, when you can say out loud what you're feeling and what you need, it becomes less powerful. Mm-hmm. It's not a big deal. I'm going to go home early today. Mm-hmm. The world will not come to an end.
That's the biggest piece, is we have to let ourselves be able to say that out loud and to give our own selves grace, because we have a lot of high achieving people on our team and we are our own worst critics. It's not people judging us. It is, we are judging ourselves. And so that's been a learning curve, I think,
It sounds like you have role modeled that very consciously, and that makes it safe, psychologically safe for others to do the same. And that's a really important kind of principle and theme for, I think, leadership in general, but especially leadership now in the midst of this chronic crisis situation. It's like the whole society is chronically critically ill. And there's no predicting the future, no clarity about when this will end, and the requirement to adjust to the new reality. So we're coming towards the end of our time. I want to ask you if there are things that you and your team have experienced over this year that you haven't had a chance to mention that you'd like to add.
Can't think of anything. I think, when we think about the hospital in general, I feel like the different professions across the board are definitely going through same changes. In nursing, there has been loss of staff, people leaving because of burnout. So we are short-staffed on nurses. I did speak to some of the ICU physicians last week. They're like, man, this is just beating us down. They experiencing things from a different level. So I think that support to everybody, the support, we palliate ourselves, we're palliating our staffs, and we're palliating our patients. Is very true.
And again, that's fascinating to me because, again, it's a theme that's come up in multiple of these breaking point conversations. And I think it's going to be one of the major learnings from the pandemic is that we market ourselves about patients and families, really, or we think of ourselves as focused on patients and families, but we need to start thinking of ourselves as equally focused on the needs of our organization and specifically those of our colleagues, because we're doing it and we should name it and be staffed appropriately to do it as well. So I'm really fascinated by the commonality of that experience. Well, thank you again so much for taking this time out of what sounds like an insanely busy every day to share your experiences with us. I'm really grateful to you.
Yes, you're very welcome. Thank you for having me.
Thank you for listening today. For debriefings, the Emotional PPE Toolkit, and more, visit capc.org/COVID-19.